diabetic food examination, the learning objectives, the major complication of the diabetics in the lower extremities, including their physical manifestation. So in these videos, we are going to learn how to examine the diabetic foot, what are the complications, and what are the signs and symptoms, and also demonstrating the diabetic foot examine, and this also designed to scan for this complication.
Today I'll be giving a demonstration of the diabetic foot exam. The term diabetic foot refers to a constellation of physical findings and medical complications in the foot arising as a consequence of impaired sensation due to diabetic neuropathy, impaired blood supply due to concurrent peripheral vascular disease, impaired wound healing and secondary infections due to the relative immunosuppression of diabetes, and last, impaired mobility in the chronically ill diabetic, which prevents him or her from routinely inspecting and caring for his or her own feet. The diabetic foot is one of the most common causes.
Okay, so let me explain a little bit. Diabetic foot, the physical findings and medical complication in the foot arising as a consequence of impaired the sensation due to the diabetic neuropathy. So everybody know that if you have the diabetic and if you do not know how to control the blood sugar level, complications start. The most common complication are diabetic retinopathy, means problem in the eye, nephropathy, diabetic nephropathy, problem in the kidney, and diabetic neuropathy, especially the nervous problem in the periphery, means extremities. So impaired the sensation. So now, like your foot touch something too hot or too cold, but your foot does not understand that it is too cold or too hot because of impairment of sensation. And if your foot or hand touch too cold and too hot and you do not understand this, your local tissue will damage. So food will be damaged because of too hot and too cold, and you do not withdraw your feet because of impairment sensation, but automatically local tissue get damaged. So ulcer formation, because of the diabetic and that is uncontrolled, this ulcer will not be healed up easily, give you pain. It is a very tough to control the diabetic ulcer. Better to prevent not to develop the ulcer. Impaired blood supply due to the concurrent peripheral vascular disease. So not only sensory problem, also impaired blood supply. If the blood supply impaired, the local tissue will not get enough oxygen and local tissue undergo ischemic change, and that is called necrosis. If you do not take care of it, necrosis lead to the gangrene formation. So bad. Impair the wound healing and secondary infection due to relative immunocompromise. Again, I say it, diabetic, if it is under control, it is okay. But if diabetic is not under control, blood sugar is goes so high, a lot of complication will start. And also, that kind of patient most of the time immunocompromised or immunosuppressed. So if the patient is immunocompromised or immunosuppressed, easily developed infection. So as a RN or LPN, you have to know what are the signs of infection. Body temperature will rise, fever. Why fever? Infection. Why infection? Because of immunocompromised patient. Why immunocompromised? Maybe uncontrolled blood sugar for a long time, impaired the mobility of chronically ill diabetic patient. It is consequence the events. If diabetic blood sugar not controlled, it will be go uncontrolled diabetes mellitus, will lead to the so many complications like neuropathy, nephropathy, retinopathy, impaired blood supply to the peripheral organ, vascular disease start, immunocompromise, and eventually all lead to immobilities, right? Or amputation even.
Causes of hospital admissions for diabetics and the leading cause of amputations in the United States. Predictors of future need for amputation include prior amputation, foot ulceration, impaired arterial supply, high hemoglobin A1C, physical deformity, and neuropathy. There are three major components of the diabetic foot exam. They are inspection, assessment of arterial supply, and assessment of neurologic function.
Okay. In this video, we are going to focus or we are going to learn how to take care, how to examine the diabetic foot. So first of all, inspection means what you can watch or what you can see. So any kind of abnormalities, deformities, damaged tissue, color change, hair loss, right? So everything. Then go for assessment of vascular supply. Question come, how I will understand blood supply is good or bad, right? Answer is, if you touch, you will get the temperature is not normal, either too cold or too warm, impaired the blood supply. Or you can see there are hair loss. This is the sign of necrosis. The skin is tiny and also shiny. So assessment neurological function as well. So there are some reflexes we can check.
Hello, Ms. Park. My name is Eric Strong. I'm going to be performing the diabetic foot exam on you today as a demonstration for some of our trainees. Do you have any questions? As with most examinations, you should begin the diabetic foot exam with inspection, with both legs exposed to above the knees. Look for
But
prior amputation.
what we learn up to here, this gentleman, how gentle way or systemic way she approached this patient. He took the permission, right? It is called patient consent. So first of all, we have to explain what we are going to do. When patient give you the permission, then we can start. This man took the permission first, then the lady, she told yes, you can, and he start to examine. First of all, say inspection, expose both leg. So you see both leg is exposed well, enough sunlight, no shadow. So expose both legs to above the knees. Look for prior amputation. So if the patient diabetic is so bad, so many complications like gangrene formation, necrosis formation, if patient need the amputation, at least we can check by inspection, right? Like to see this lady's feet, you can see the color. It is okay. It is little bit pink. Blood supply is good. And their symmetry, both when you check this one, you have to same time check the other one. It's called symmetry. Any kind of deformities, any kind of the pattern of the hair, right? So everything including in inspection. So if any swelling, any tumor, any mass, everything will be, any ulcer is there or not.
And assess for general foot hygiene. Look for dryness and cracking of the feet, superficial fungal infections, and good nail care. Inadequate hygiene is a risk factor for developing infections. Even mild skin cracking or a superficial fungal infection could serve as a potential portal of entry for more serious bacterial infections. Assess the hair pattern. An asymmetric absence of hair or abrupt change in hair pattern as one moves distally down a leg suggests arterial insufficiency. Look for calluses, which may be a sign of improperly fitting footwear and may precede ulcer development. Ulcerations may be...
So now, the point, expose both leg, then look for any kind of amputation is there or not. Assess the general food hygiene. Just check it. Is it clean or not? Any infection or not? So assess for hair pattern and look for any kind of ulceration. Like this picture, in the heel, this bad ulcer. Most of the time, if you diabetes, if you have diabetic, and if you are not able to control your blood sugar, how you have to control your ulcer, right? Unless you do not control the blood sugar in the blood, this ulcer will not heal it up, right?
Due not just to repeated trauma, but also arterial insufficiency due to concurrent...
You see, my friend, it might be at the beginning look like this, but now, you see, the level of the stage of ulcer, the blackening, very wide, almost the fascia is look like. The discharge is there, congestion, edematous, how bad it is. But before to control this ulcer, you have to control your blood sugar first.
Peripheral vascular disease, or from concurrent venous stasis. And the presence of an ulcer does not necessarily indicate infection. Signs of infection include surrounding erythema, tenderness, and purulent drainage. Osteomyelitis is likely if either bone is visible within the ulceration or if the bone can be reached by examining the ulcer with a sterile probe. Also inspect for joint deformities. These include metatarsal subluxation, which is usually seen with the first MTP joint. The first MTP joint can be vertically subluxed, or more commonly, laterally subluxed, which creates a pressure point on the joint's medial surface. This is what is known as a bunion, and is formally referred to as hallux abducto-valgus deformity. Bunions are not caused by diabetes per se, but can complicate the treatment of the diabetic foot. Another pair of related deformities are the claw toe and hammer toe, which are due to combinations of vertical subluxations of the MTP, PIP, and DIP joints, which often happens to toes 2 through 5 simultaneously. The more dramatic deformity seen in diabetes is called neuropathic arthropathy, or more commonly, the Charcot foot, which is a pattern of destructive changes due to repetitive trauma to insensate joints. Early features include edema, warmth, and erythema surrounding affected joints. Later features include overt joint deformity, joint dislocations, pathologic fractures, and overlying skin ulcerations.
So you see, in this foot, that these two are not look like same, right? This one is edematous, so I can say they are not symmetrical, is asymmetrical. And also this is the one kind of scar mark there. And here we can see it is deformed, right? And also they are maybe a lot of fluid is accumulate there. So I said, when we check, we could check everything.
Neuropathic arthropathy is not specific for diabetes, as it's also seen in other etiologies of peripheral neuropathy, including alcoholism, HIV, and syphilis. The most extreme form of Charcot foot is the so-called rocker bottom foot deformity, in which the normal arch of the foot becomes everted, leading to a dangerous pressure point in the midfoot. Before leaving inspection, be sure to examine the patient's footwear. Abnormal patterns of wear may suggest improperly fitting shoes and/or an abnormal gait, which can be an early sign of neuropathic arthropathy.
Okay, so we are LPN or RN, right? So it is our responsibilities to check the footwear. What footwear supposed to patient should wear? And is it fitting well? Is it comfortable for his or her? What are the materials make for?
The next part of the exam is an assessment of the vascular supply. This begins with checking the temperature in the legs, ensuring that they are equally warm. At this point, the formal diabetic foot exam would also assess capillary refill, in which the nail of the great toe is compressed and the time to reperfuse the nail bed is measured. However, this exam finding has been demonstrated in the literature to be of little value in assessing for peripheral vascular disease, which is consistent with my own personal experience, and thus I omit it. Then we check the peripheral pulses. Always start assessment of pulses as distally as possible, and only bother with more proximal pulses if the distal ones are abnormal. The most distal pulses in the leg are first the dorsalis pedis pulse, which is found just lateral to the extensor tendon of the great toe, and second, the posterior tibial.
Okay, so now first of all, here showing, so assess the temperature. So we can check the temperature of the foot. Everyone would understand, I believe. Then we can see the capillary refill. So you can press the capillary and then hold for 30 seconds. And after that, you withdraw your pressure and then check how long take time to rebag the blood or rebag the color of the foot. And this is called capillary refill. So let me recap it about the capillary refill. NCLEX PN and NCLEX RN board asked this question: how long you have to hold the pressure and how long usually come back the original color, or how long take time to rebag the blood supply. So capillary refill time, the board asked this question. So actually the capillary refill time is defined as the time taken for the color to return to an external capillary bed after pressure is applied to the cause of blanching. So it can be measured by holding a hand higher than the heart level and pressure the soft bed of a finger or fingernail until it returns white. Then taking the note of the time needed for the color to return once pressure is released. And usually the time take 2 seconds for a normal capillary refill time. This is the question NCLEX would ask. How long take time to refill? It is usually less than 2 seconds. Okay, it's called the capillary refill time, 2 seconds. Another one is called access the distal pulses. So most distally, it is called dorsalis pedis. We can check it. You can feel it or do not. Interval per beat is normal or irregular or regular. And posterior tibial. So you can see this is the bones, and this bones is called middle malleolus, and this is called tendoaquilus. So if you put your finger in between middle malleolus and tendoaquilus, you can feel the pulsation, and that is called posterior tibial arteries.
Pulse, which is found posterior and inferior to the medial malleolus. In the event that either of these is abnormal, you should follow it with assessment of the popliteal pulse. This is found in the midline within the popliteal fossa behind the knee and is best felt with a hand wrapped around the knee from the front and pressure applied while the knee is relaxed in moderate flexion. When it comes time to describe the strength of a patient's pulse, despite occasional insistence to the contrary, there is no specific standardized numerical scale to use. Therefore, pulses are best described qualitatively as absent, present but diminished, normal, or bounding. Any abnormalities that suggest the presence of peripheral vascular disease should be further investigated with measurement of the ankle brachial index.
Okay, so basically when you examine the arteries or pulses, check is it absence or present, right? Very easy. So absence or presence. If present, is it normal or diminished? Okay, and also we will check the boundings. Is it bounding pulse or not?
The last of the three main sections of the diabetic foot exam is assessment of neurologic function, beginning with sensation. Ms. Park, I'm next going to evaluate vibration sense in your feet with a tuning fork. Can you hold your arm out? And can you feel that?
Yes.
And do you feel it stopped?
Yes.
Okay, I'm going to check the same thing in your feet now with your eyes closed.
Okay.
All right, so let me know when you can feel the vibration, and then let me know when you can no longer feel it.
Okay. Yes. It's gone.
On the other side?
Yes. It's gone.
Ms. Park, next, with your eyes closed, I'm going to lift your great toe, either up or down, and I want you to tell me which direction you think it's being moved.
Okay.
Okay.
So here talking about the neurological function, right? So this man bring a hammer or bring a tuning fork to see the sensation and to see the vibration or proprioception. So first of all, we have to know what are the symptoms of diabetic neuropathy, because this neurological function check for to exclude if have any kind of diabetic neuropathy there or not. Usually the patient who have the problem or complication of diabetic, it will be sensitivity to touch, or patient complain loss of sensation of touch, or difficult with a coordination when walking, or numbness, or some patient explain the pain in the hand or feet, burning sensation in feet, especially at the night, muscle weakness or muscle wasting, also always feel the fullness or bloating. Even sometimes patient complain nausea, indigestion, and vomiting. Okay, so the what kind of problem, neurological problem actually occur where or why it is occur? So always remember, in case of diabetic foot, the nerve damage occur in the periphery, and nerve damage can affect a patient hand or foot, legs or arms, because high blood sugar can lead to nerve damage, what we call diabetic neuropathy. And we can prevent it or slow this progress by keeping the blood sugar within target range. Target range as possible, and maintain the healthy lifestyle. But my question, what happens when diabetic affect the food? This is the reason this man examined this lady's food. Over time, the diabetic may cause the severe nerve damage, also cause diabetic neuropathy, and that can cause the tingling and pain, and can make you lose the feelings in the foot. When the patient loses the feelings in the foot, they may not feel a inside the shock or blister on the foot. So when patient lost the sensation, they lost the sensation of the blister or ulcer formation on the foot. So they will be careless because of lack of sensation, even which can lead to cut and sore on the foot. Let's continue.
Down. Down. Up.
On the other side?
Up. Up. Down. Up.
Great. The sensory exam typically ends with a monofilament test. In the conventional monofilament test, the patient lies supine with eyes closed, while the examiner touches various points on both feet with the monofilament, using enough pressure to cause it to buckle. The patient indicates when he or she feels the monofilament touching them. Despite some claims to the contrary, as with a pulse scale, there is no one standard as to the specific spots on the foot where the patient should be touched. However, a reasonable list of locations would include the plantar surfaces of the first and fifth toe, and of the first and fifth MTP joints, plus or minus the center of the heel. The test is generally considered to be abnormal if the patient is unable to feel the sensation at any one site. The conventional monofilament used in this test is called the 5.07 monofilament, which defines the amount of force the monofilament imparts to the skin before it buckles. Ms. Park, with your eyes closed, I'd like you to tell me when you feel this monofilament touching the bottom of your foot.
Yes. 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 Yes.
It's called
Yes.
monofilament test, right? After these videos, I am going to discuss a little bit about diabetic neuropathy and peripheral arterial disease, because what are the difference between diabetic neuropathy and peripheral neuropathy? This is the question arise in your mind. So let me recap it. I said, what are the difference between diabetic neuropathy and peripheral neuropathy? So peripheral neuropathy is a nerve damage most often caused by diabetic. Hence, it is also referred to as a diabetic peripheral neuropathy. And it is a result of prolonged elevated level of blood sugar. Keep in mind, diabetic neuropathy and peripheral arterial disease is not the same things. Diabetic neuropathy and peripheral arterial disease are two distinct but related conditions. They are associated because they both affect the similar population and causes some of the same complication, but this has led to some confusion, and this confusion around the disease definition of diabetic neuropathy with peripheral arterial disease. I said this is two distinct patterns, but the both have a similar complication. So peripheral neuropathy is a nerve damage, I said. And this nerve damage most often caused by diabetic. Hence, it is called diabetic peripheral neuropathy. And diabetic peripheral neuropathy usually present as a pain in the form of burning sensation or tingling sensation, and general weakness in the limb, and usually in the patient legs, feet, or hand. If not addressed, diabetic neuropathy may develop into complete nervousness and atrophy. And this is really a serious complication. Also, it is important due to the lack of feelings, or patient may miss the sign of infection because sensation is no more there, right? And this infection from minor injury such as a blister or cut, which could lead to a major infection and possible need to amputation. Also, nerve damage from diabetic can cause problem with internal organs such as the digestive tract, heart, and sexual organ. It is estimated that up to around 70% people with diabetic have mild to severe neuropathy. Here we are discussing about or compare contrast diabetic peripheral neuropathy and peripheral arterial disease. Let me tell something about peripheral arterial disease, shortly called PAD. PAD is a narrowing of the artery most commonly found in the lower extremities, means leg or thigh, hip or buttock. Peripheral arterial pain symptoms include patient complain about the aching type of pain or cramping nature of pain or numbness and weakness that occur when walking or clumping the stair or when they do the exercise, pain start. This discomfort goes away when the patient take rest, and this is called intermittent claudication, and which can limit the activities and your, quality of life will be go down, right? So the peripheral arterial disease is a chronic disease which which make a or which lead to formation the plug or build the plug up or due to the atherosclerosis and making it difficult for blood to circulate through the arteries. Peripheral artery progression, progressive happen when the blood flow in the artery become completely compromised or blocked, or although the serious blood clot can form when plug breaks off or enter the bloodstream, right? So this peripheral arterial disease leads to the blood clot formation, and this clot go in the circulation. When this clot go through the microcirculation, they fall in stuck and blood supply will be arrested. This blood clot, when passing through the brain, they can lead to the stroke. When this blood clot passing through the microcirculation in the lungs or pulmonary circulation, they can lead to pulmonary embolism, and that is life-threatening condition, right? So you see the consequence of diabetic, how dangerous it is.
Yes. 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 Yes.
All right, great, thank you. Some clinicians also include assessment of pain by randomly touching different parts of the foot with either the sharp or dull side of a broken cotton-tipped applicator or tongue depressor. If the prior sensory modalities are normal and the patient has no sensory complaints, I personally omit this section as well. The next component of the foot-focused neuroexam is a check of the ankle reflex. This is most commonly done with the patient sitting upright, but anyone who has actually attempted to elicit this reflex in this position can appreciate it is awkward and difficult to perform. Therefore, I advise checking the ankle reflex with the patient supine, with the hip externally rotated, knee flexed, and ankle in mild dorsiflexion in order to stretch the Achilles tendon.
Okay,
The final component of the exam.
This one is called ankle reflex, or some books said ankle jerk reflex. You see, this man, this area is called popliteal fossa. Okay, in the hand is called cubital fossa. So this is the tendon is there. When the hammer is pressure this area, trigger this area, he can see the jerkness of the muscle. So the ankle jerk reflex, also known as the Aquilas reflex, because all of the muscle finally end with the tendo-Achilles here. Okay, so Achilles reflex or ankle jerk reflex occurs when the Achilles tendon is trapped, when the foot is dorsiflexed. This foot is dorsiflexed. Okay, so this is important. This is called the ankle reflex.
Knee flexed, and ankle in mild dorsiflexion in order to stretch the Achilles tendon. The final component of the exam is assessment of gait. It should be assessed for smoothness and symmetry. Gait abnormalities may be indicative of neuropathy and/or early neuropathic arthropathy.
So what this man,
Well, Ms. Park, that's the end of the exam. I just want to let you know everything was healthy and normal.
okay, what this means, what few minutes ago, watching the movement of walking or a person's manner of walking. So this is the way to examine the diabetic foot.